The information in this podcast is provided for informational purposes only. You should not use any information discussed in this podcast and related materials to make medical or healthcare related decisions. Always consult your physician or other qualified healthcare provider with regards to diagnosing and managing your medical condition. Any medications or treatments, including any discussed in this podcast, should be initiated and managed by a qualified healthcare professional. Welcome to LongCovid The Answers. Today's episode 4 is entitled Diagnosing and Managing Long COVID in Children and is the second of a two-part series of episodes about pediatric long haulers. I'd like to introduce Dr. Danilo Buonsenso, who is a physician scientist and a specialist in infectious diseases in children. Dr. Buonsenso currently works at the Department of Women, Child and Public Health at the Gemelli University Hospital in Rome, Italy. He has a PhD in Public Health and Biomolecular Sciences and is currently doing his MSc in Infectious Disease at Oxford University. During the pandemic, his work extended to the clinical impact of SARS-CoV-2 infection in children from acute disease, multi-system inflammatory syndrome in children, or MIS-C, and long COVID. He is a founder and president of the not-for-profit organization Surf for Children, which provides medical support for children in Sierra Leone and special needs support for children in Italy. He is also a champion of the charity Long COVID Kids. Welcome.
Thank you very much for your introduction. I'm very happy to be here.
And we're very happy to have you. Do you have any conflicts of interest to declare, Danilo?
Yes, I have to declare that I have been founded by Pfizer and Roche for two studies I'm still currently coordinating within the field of long COVID. The founders had no role in the development or the plan of these studies, and also no role in the interpretation and dissemination of data and results.
Excellent, thank you. And of course, they have no role or contribution in this interview. I'd like to now consider how a physician or parent would go about looking for long COVID symptoms in a child. Given the widespread perception that children are rarely impacted by COVID, I believe long COVID is either underdiagnosed or misdiagnosed. Are you in agreement with this, Danilo?
Yes, I think so, because the pattern of signs and symptoms are very much evident for the family, but may still be overlooked as a psychological problem by the healthcare professionals. It can be a real possibility that long COVID is still not entirely recognized in many settings.
Does the presentation of long COVID differ between adults and children?
No, I would say that the presentation is very much similar. So in children, at least in my experience, it is very much uncommon before 8 to 10 years of age. It is possible, but it is uncommon, or maybe can be more difficult to be recognized, of course, because children interact less. But overall, in the large majority of cases, the classic presentation is very much similar in a 15 years old and in a 30, 25, 40 years old boy, women or men. And the presentation, in my opinion, is quite characteristic, because the classic presentation is that a child who was perfectly healthy, playing football or volleyball, whatever, basketball in the US, maybe more frequently every day, he got COVID or she got COVID, and then is so fatigued, he has so much fatigue that he struggle even to do a floor of stairs. They sleep a lot. Any minimal activity lead to a general malaise, very high tachycardia. Some can have muscle and joint pains, which lead to lay down most of the day. Some can have cognitive issues like brain fogs, drop in the school performance. All these symptoms significantly change the routine of these children, but most importantly, they sooner or later will also impact their mental health, because you can imagine a perfectly well child routine is completely changed. No one can tell you why your child is now severely ill, because they look very healthy. This is one of the problems with long COVID, because these children look healthy, and so people have difficulty in trusting the disease of these children. So they are not trusted, the mental health is obviously impacted, and these children start missing school, missing friends, which in turn further worsen the physical and the mental health symptoms. And therefore, it's very much important to recognize the disease, because recognizing the disease can offer the possibility to enter research sector studies, but also to try to implement recognition from parents, school teachers, sport teachers, friends, and also supporting any conditions that we may still treat within long COVID.
That's an excellent answer and preempted one of the questions I was going to ask. What's crossing my mind is the prevalence of long COVID. In adults, depending on what study you look at, we're looking at between 15 and 30% of adults infected with SARS-CoV-2, and probably a resting population incidence of between 5 and 7% of the adult population. What's the prevalence, in your opinion, of long COVID in children?
So this is still a topic of debate. If you probably ask 10 different people, you will get 10 different answers. So I'll try to give a balanced perspective. So as you may know, many reviews report like from 5 to 20% of children having long COVID. But in my opinion, this figure is too much figure, because otherwise we will be in a very catastrophic scenario. Luckily, we still see that most children are healthy and attend school or whatever. So probably I think the best figure nowadays comes from a Scandinavian paper, which was able to do a nationwide assessment of children with or without COVID-19. And in this context, I guess that the difference between the two groups was that 0.2% of children with COVID have a possible long COVID diagnosis. The 0.2% may look a small number, but as I told you in the previous episode, if you consider that the massive number of children infected with COVID-19, this is going to be a huge number. In terms of absolute number, I remember when during the first months of the pandemic, there was a debate again about the prevalence of long COVID. I used to say that even if we have 0.1% of children with COVID getting long COVID, this is going to be a huge number. This study actually doubled my prediction to 0.2%. So probably 0.1 is the number I will guess according to the available literature. And this is a huge number of children having long-term issues. It's important that people do not do the same mistake as with COVID, that 0.1 is so small that is no children get long COVID. No, 0.1 is a relatively small risk for the individual, but is a massive number of children having chronic symptoms impairing daily life that we still do not know perfectly how to treat. And therefore, it's a significant impact on healthcare systems, but also on families.
Thank you. The frequency of long COVID varies depending on the age group and sex. It seems to affect girls more frequently and older children more severely. Why?
Yes, most older children seem clearly have more frequently long COVID compared to younger children. The exact reasons are still unknown. There are some possibilities. So first of all, older children are maybe more aware of these subtle problems compared, for example, to younger children, like the neurocognitive issues, the change in school performance can be much easier to be evaluated in a 14-year-old, which is like an adult nowadays, compared to a very young children. And even the feeling of fatigue, muscle pains, and whatever. From one hand, it can be due to easier recognition in older children. Second, the other point can be that an old adolescence is very much similar to a young woman or a young man, even in terms of immunological background, protective mechanisms, and the endothelial balance, and whatever. So we probably have both. We have a cohort of patients that are similar to young adults, both physically, immunologically, and also some subtle symptoms. For example, the palpitations can be more easily recognized in this cohort.
Okay. What about the gender difference? Why more girls than boys, do you think?
So this difference is not that strong in pediatrics. It's more evident in children, but of course we are still seeing a bit more girls than boys having long COVID. This is something that is happening in many diseases. We have a whole field of medicine which is focused on gender medicine, which is trying to explain why several outcomes are different in adults, in female and males. We know the difference in terms of hormonal homeostasis are clearly different in males and females. And these differences are in line with the differences we have in other autoimmune diseases. So we know that even other autoimmune diseases are much more frequently in adults, in females than males. And this should not come as a surprise that even in long COVID, we are seeing a similar difference, because we know that long COVID, we are having growing and growing evidence that from an immunological perspective, there is a role of the immune system also in long COVID. And so again, this is in line with autoimmunity differences in female and males, and probably there is still some role from how the hormones, sexual hormones, or other behavioral and social factors affects the manifestation of diseases.
Okay, thank you. If we categorize children into different age groups, say 0 to 1 years, 1 to 7 years, 7 to 12 years, and teenagers, what are the diagnostic methods for identifying long COVID in children? Because, for instance, a young child between the ages of 0 and 1 may cry to express joint pain, but how could you really discern that as a clinician? What's your approach in those different age groups with regards to diagnosis?
This is a problem we have in pediatrics, and definitely this is a good point, because as I said before, the group 10 to 12s and older are those that are much easier to investigate, because first of all, they can report some symptoms better than others. The neurocognitive tests are more easily done in the older children. For the cardiopulmonary exercise testing, for example, is an effort test we do on a cyclet. And not most centers have cyclet available for patients taller than 140 centimeters. Many tests are more difficult to done in children, like the lung function tests in less collaborative children are much more difficult to be done. This is probably one of the reasons why we can easily recognize long COVID in teenagers. We see much less long COVID under the year of 6, because in this age group, children may not even be recognized for first diagnostics, because they don't tell you, I have brain fog or symptoms like that. So in the younger children, in my opinion, there is a whole gap of literature, and probably this is exactly one of the main reasons. It's more easier to recognize some objective symptoms, like in this cohort, I see more frequently children with chronic gastrointestinal issues like chronic nausea, vomiting, or diarrhea, which are easy to be recognized even in younger children. But overall, it's very difficult.
Colleagues have said to me that they really struggle. They would to assess long COVID in children in the community setting. So, how would you go about diagnosing long COVID in children in family medicine?
Yeah, this is a real challenge in the community setting, because long COVID is a real multisystemic disease, and a multidisciplinary approach, in my opinion, is extremely important, particularly nowadays when we do not yet have the full picture of the disease. I will tell you what we do, but I think the first suggestion for a community doctor is to link with some center that do have a multidisciplinary approach, because in my opinion, on the community, it's very difficult to organize all the necessary steps. Of course, this can differ a lot between countries, because healthcare systems can have significant differences in terms of organization. But in general, in my opinion, a team and a leader of multidisciplinary colleagues is necessary. When children report persisting symptoms that are suspected for long COVID, we first of all do, and this is something I suggest the community doctors, even in my setting, I first suggest to do a baseline assessment of first level tests for any differential that might explain fatigue, for example. Fatigue is a hallmark of long COVID, but can also be a sign, a symptom of a chronic anemia or hypothyroidism, for example. And in my opinion, this should be excluded. Or type 1 diabetes has a period of weeks to months that can only have as only complaint fatigue before it becomes ketoacidosis. These diseases with a simple blood test should be ruled out. Chronic abdominal pains, nausea, vomiting, diarrhea can be another significant presentation of long COVID, but also of celiac disease. We know that any autoimmune diseases, also celiac disease, can be triggered by some viral infections. This is another disease that it's easy to be excluded in the community setting. Or a screening for autoimmune diseases, because patients with long COVID can have chronic joint pains like rheumatoid arthritis or lupus. And again, an autoimmunity screening can be feasible in the community setting. In my opinion, it's important to exclude this diagnosis because sometimes people focus on long COVID and forget to treat hypothyroidism or miss a diagnosis of type 1 diabetes. Therefore, try to exclude easily treatable conditions, and this should be done as a first approach in the community setting. Once you exclude this and symptoms persist, refer to a center. According to your organization, you can organize some tests like the cardiopulmonary exercise testing, as I was telling you before. It's easy to be done. It's non-invasive. Usually can be done in every setting in younger children. It makes objective that this patient is not able to finish the effort, or malaise, or has some deconditioning or inappropriate cardiorespiratory response to the effort. It's good in terms of diagnostics, and also it's important to show the family and the child that something objective is going on and it's not only a psychological complaint. Parallel, another very easy test I do in these patients is a 10 minutes 10 test and a 24 hours electrocardiogram, which both can show you inappropriate heart rate responses with minimal efforts, like passing from standing position to upper position, or the 24 hours electrocardiogram sometimes can show you that the heart rate of these patients has mean values very high, even when resting or just working, patients have this heart rate goes up and down. And this is another important point, because if you find postural orthostatic tachycardia syndrome or dysautonomia, we already have many societies that provides indication on how to manage dysautonomia in children. So whatever it is post-COVID or not, we have some guidelines and we can follow, and potentially we can treat some symptoms. So this is another thing that, in my opinion, is better if this is all done within a multidisciplinary team and within research setting, because we still need to understand. But, in case no one in your setting is gonna do this, you can organize this test, and maybe you can also discuss online with other doctors that are even far away, but at least you can present some of these tests. Another point, an important role is, of course, played by the neurologists and the neuropsychiatrists for two reasons. One reason is that chronic headache and chronic pains are a hallmark of long COVID. And again, these symptoms, unfortunately, are mostly never treated in children. This is a paradox because we have, since decades, very good guidelines for chronic headache. So what we do in my setting is that if we have a child with chronic headache post-COVID, We have the guidelines for headache and we simply follow them. It doesn't changing if we have post-COVID headache or idiopathic headache or post-varicella headache. We have the guidelines. The specificity of long COVID children is that most of the time they are not responsive to first line approaches. So you need to be brave, but this is not bravery because you have the guidelines to treat according to the steps for severe headaches. And this is another thing that it's in theory feasible also in the community setting if you have the expertise. Again, chronic headache most of the time is treatable. And once you treat chronic headache, you can improve sleeping, you can improve school performance, you can improve the time children are able to spend at school or out of home with friends and whatever. So this is obviously, and also the neuropsychiatrists and psychologists are needed again. This also can be done in the community because, as I told you in the previous episode, the mental health of these children is impaired and affected, but not because this is a psychological or psychiatric disease. But the mental health is impaired because the routine life of these children is disrupted quite suddenly. I'm a father. I don't know about you, but imagine having your child, 12 years old, that was going out every day and now is laying at bed every day. Of course, the mental health is impaired. Therefore, it's important to have at a community level a specialist that can teach the child how to deal with the new routine. Okay, because how to learn strategies to do the minimal amount of effort that you are able to tolerate without going farther this level, but also because it's important not to stress too much patients that suffer from fatigue and post-exertional malaise. But it's also important to tell, okay, lay down on the bed every day. You need to learn that level that allows your body to keep a minimal level of activity, because otherwise, the less you do, the less you will do. And it's important that you accept this new yourself while you hopefully are entered in research settings and hopefully you will get better in the future. Of course, you will ask patients, at least in my experience, will accept this new life if they have the hope to be trusted in a research and academic or hospital setting, hoping that you have a team that at least is trying to understand your condition.
Thank you. We're really under-resourced here in British Columbia in Canada. All of the long COVID clinics were shut about a year ago. I don't think the differential diagnosis is even brought into the equation with most clinicians. And really, we don't have any idea what pediatricians specialize in long COVID in our area. I think that's the case for many different places. Do you know of any online resource where parents can access or GPs can access to get information or to maybe interact with a clinician like yourself who has interest?
Yeah, there are some. So I totally understand your point because it's a reality in many settings. To try to overcome this point, there are some possibilities. So, first of all, many countries organize parents' associations. Like nowadays, the mother of these associations, I don't know, I have no conflict of interest with them. So the first I know of this kind of associations is Long COVID Kids UK, but I know that similar associations raised in other countries like Long COVID Kids USA, probably also Long COVID Kids Canada, Scotland, and whatever. So parents association, in my opinion, are useful because first of all, can provide some kind of support. Maybe some other parents can know another specialist in the area, but also parents association can have also a political role to raise awareness and funding, but also can link adolescents or children between each other, because sometimes even talking with a pair can be useful. Secondly, some of us, for example, I have a blog which is available online as it is free access, but I am sure there are other doctors doing similar or even better job. I try to update the resources, and I try to discuss sometimes with parents as well if they want second opinion, or anyway discuss about potential things that might be done. In terms of research, we implemented an international network called IP4C, which is an international network for post-COVID condition in children. And we meet every 2 months online to discuss updates, to share stories from parents, patients, whatever. We also invite parents to take part to these meetings every 2 months. Parents can also email to be in contact, which is ip4c.longcovid@gmail.com. So there are some opportunities. Hopefully there will be more. Yeah, I understand that not in every settings, because dealing with long COVID is extremely expensive. This is true. This I'm gonna say this in defense of my colleagues, because dealing with long COVID requires a huge amount of time and a huge amount of healthcare resources. So sometimes, according to the organization of your health systems, sometimes doctors are not allowed. They would like to do some of these diagnostics, but some healthcare systems do not even allow these tests. Maybe in some countries that are based on insurances, it varies a lot. Even in Italy, some hospitals can and some hospital cannot. And this means that there is also a political problem. Sometimes it's not ignorance by pediatricians or colleagues, but it's a political problem in terms of accessibility to needed resources.
Yeah, thank you. We've run out of time. Do you have time for one more question?
Yeah.
Danilo, no recognized treatments or cures exist for long COVID in children or adults. What treatment options would you like to see researched for children?
Yes, it is true that there are no official therapies because we don't know the root yet, but there are some treatable conditions and there are some dream trials that I wish we will be able to implement soon. So about the already available opportunities, as I told you before, we have options to treat posterior orthostatic tachycardia syndrome, where we recognize them. In my experience, we use a lot ivabratin, for example, when we recognize spots in children. Or for chronic headache, for example, we have, when it is severe enough to arrive to third step of treatment with headaches, for example, we have options like pregabalin, gabapentin, for example, and other options that are already available in the guidelines. About a promising trial, I think it will be definitely worth it to trial anti-aggregation or anticoagulation in long COVID. We know that there is growing evidence that the endothelial system is impaired in patients after COVID-19. In adults, the evidence is quite strong. Just a few days ago, another major study published on Science also documented abnormal clotting, complement activation, and endothelial abnormalities. In the pilot studies we are doing, we have also documented on it an overexpression of a protein which is called CD62, which is implicated in platelet activation, suggesting that again there is some factor probably at the endothelium level that overactivate the platelets. We also have recent studies showing chronic platelet infection with SARS-CoV-2. So the endothelial system is really a hot topic. It is also reasonable because we know that long COVID is a systemic disease, and the only cells that we find everywhere are the endothelial cells, which are the cells that form our vessels. Okay, so they are everywhere. So we have the neurocognitive symptoms, the cardiac symptoms, the respiratory, muscle, joint symptoms. Everywhere in these organs, we have the endothelial cells. And the endothelial cells are those cells that put in communication our blood with our cells. and also have a role in terms of connection with the immune system. So if we consider this background and the recent studies I showed you, targeting the endothelial cells, in my opinion, is extremely fascinating. So I don't want to say it will work, but in my opinion, will be nowadays, with current level of knowledge, the best trial to focus on. We know that some of the anticoagulants sometimes we have used in the most severe case not only prevent clotting formation, but also have pleiotropic effect on the endothelial cells, kind of a protective role on the endothelial cells. And in my opinion, this is an important field of investigation, of course, with a randomized control trial and trialing safe levels of medications, because of course the problem with these medications that should never be used alone by parents is that they can cause excessive bleeding, which sometimes can be severe and also life-threatening.
Thank you. And just for our non-medical audience, endothelial cells are the cells that line our blood vessels, and anticoagulants are blood thinners. Thank you so much, Danilo. I know we've run a little bit over time and you have to go on call now. Thank you for taking the time to share the depth and breadth of the information that you have. Yes, just really grateful that we could do this interview today.
My pleasure, really. It was really helpful for me too. I hope this will help someone.
Thank you very much. Some questions for listeners to consider. What are your top 5 takeaways from this episode? How will this episode change your practice or perception of this disease? What will you do to act on what you've learned? Please discuss your thoughts on our social media outlets, Twitter or X, the website blog, Instagram, Facebook, or LinkedIn. Please rate this episode.